what we're talking about today is anesthesia for epilepsy surgery, so it seems reasonable to start with a little bit of a discussion about epilepsy and anesthesia as a starting point. So one thing is what's the definition of epilepsy, and the definition of epilepsy is the clinical syndrome of recurring seizures. Simple. Remarkably, there are 2 million people with epilepsy in the United States and 50 million worldwide. So it's a much more, perhaps, common disease than you would necessarily be aware of if you hadn't recently heard those numbers. And a very debilitating disease, as you know. Seizures are basically an abnormal discharge of a population of neurons. And what happens when you have a seizure depends on where that abnormal neuronal discharge occurs in your brain. So you could have movement, people have sensory experiences when they have seizures, visual, olfactory, auditory hallucinations. All of those phenomena can occur during seizures. I had a patient several years ago who had a sensory phenomenon with the seizures of an electric shock that was so severe it was literally unbearable to him. So lots of different protein things can happen when people have seizures. And I'm not going to go into the entire descriptor of all the different kinds of seizures, because that would take up the entire half hour, and we're going to concentrate on anesthesia and epilepsy. But I do want to make a point about the differentiation between a partial and a generalized seizure. So a partial seizure basically arises in part of the brain, and a generalized seizure involves the entire, both hemispheres simultaneously. And partial seizures can secondarily generalize. So with a generalized seizure, consciousness is always lost, and with a partial seizure, it can be retained or lost. So those are sort of things to just be aware of that will help understand what's happening in clinical situations in patients with these kinds of seizure disorders. Most of the time, the cause of seizures is unknown, but they do occur as a result of structural abnormalities like head trauma, brain tumors, stroke, infection, and an injury during the prenatal period. There are also some syndromes that are associated with epilepsy that have some implications for anesthesia, so you probably should have some basic familiarity with these. Patients with Sturge-Weber commonly have epilepsy, and they have port wine stains in the olfactory division of the trigeminal nerve, which doesn't really make any difference to anesthesia. But what does make a difference to anesthesia is that they have angiomas not only of their brain and tumors, but also angiomas of the airway. So it's important to be aware of that when you're managing their care. Another syndrome associated with epilepsy is Lennox-Gastaut syndrome, and that those patients are very significantly developmentally delayed often, and they have very abnormal resting EKGs even when they're not having a seizure. The main issue for anesthesia probably for these patients is the developmental delay issues. And the third syndrome that's associated with epilepsy is tuberous sclerosis, and patients with tuberous sclerosis have tumors in their brain. Epilepsy, they also have tumors in their heart, as you can see at the bottom right over there, which may actually be functionally significant. They have tumors in their kidneys, which may cause renal injury, and they may have conduction abnormalities, again related to involvement of the heart. So knowing those things in advance helps you with your preoperative evaluation, and hopefully that's helpful to you. Now, treatment of epilepsy. The first line treatment is medical. Obviously everybody doesn't like get diagnosed with epilepsy and come for surgery. So there are a lot of drugs used to treat epilepsy. They're usually called anti-epileptic drugs or AEDs, and you'll hear that used a lot, so it's worthwhile to know the term. And they're basically divided into two different groups. The drugs that have been around since before you were born, and in some cases before I was born, for a very long time. And then newer drugs which were developed in the 1990s to try and improve epilepsy medical control. And so you should be familiar with these drugs, and the things that you want to be familiar with about them are basically three things. You want to know how they affect sodium balance, how they affect acid-base balance, and how they affect coagulation. You want to know how they interact with anesthetics and drugs that we use in anesthesia. And you want to know how to give them intraoperatively. So those, I think, sort of summarizes the things that you need to know. There's lots of other interesting things about them, but those are the main things that we need to all be aware of. So with regard to sodium balance, two of the drugs, carbamazepine and oxcarbamazepine, there's some spelling errors here, I apologize, that cause decreases in serum sodium. And it can be clinically significant. I mean, symptomatic hyponatremia can be caused by these drugs. And the incidence is higher in children than it is in adults. The implication for us is we need to check the sodium preoperatively, and if we have a patient who comes in with a sodium of 25 and they're on one of these drugs, we may be able to make an association that is useful, although other causes always should be considered. Several of these drugs cause significant, so that's the mechanism of the hyponatremia is effect on renal tubules, either of the drugs themselves or through enhancing response to ADH. Two of the drugs that are commonly used, Topamax and Zonogram, cause significant bicarb losses due to carbonic anhydrase, effects on carbonic anhydrase. And I think I probably mentioned to some of you in the operating room that when we first started having the patients prescribe these drugs, people were bringing their children into the ER because they were hyperventilating, and they were hyperventilating because they were getting acidotic from the effect of these drugs. So it's more common in children than adults. But again, check bicarb, and if the bicarb is low and they're on that drug, you have some useful information. Now the third category of issues, coagulation, is more difficult to tell you exactly what to do about it, because there are multiple case reports in the literature of patients having coagulopathy related to Depakote, who are on Depakote, I should say. And there are some studies that showed some platelet dysfunction in the past. More recent studies, however, using in vitro studies of platelet function, suggest that, in fact, Depakote doesn't have any effect. But there is a lingering concern regarding this based on the many clinical reports of problems. So when you have patients on Depakote and they're having procedures where hemorrhage would be very, very adverse, such as neurosurgery, it is a good idea to probably have a conversation with the surgical team about that prior to starting your procedure. Now, the third thing that I mentioned that we want to be able to do is to anticipate the kinds of interactions that we're going to have with the medications that we use intraoperatively. So the cytochrome P450 inducer, so there are three mechanisms really. Liver enzyme induction and protein binding, and then there are some more exotic ones like inhibition of acetylcholine release at the neuromuscular end plate, and then there are also additive sedative effects which are important to think about. So the drugs that I have highlighted here in red are the drugs that are significant liver enzyme inducers. And one drug, valproic acid, actually inhibits liver enzymes. And here are the things that we do know result when patients are on anti-epileptic drugs. One is that narcotic requirements may be increased. This has been studied for fentanyl. And when they looked at requirements based on certain, on a response to certain physiologic parameters, if blood pressure went up X, they gave this amount of drug. It was clear that the requirements for fentanyl were increased. The most marked thing, and I think all of us are familiar with this, is the dramatic decrease in the duration of action of neuromuscular blockers of the aminosteroid group. Specifically, the ones we commonly use would be rocuronium and vecuronium. And this effect can be so dramatic that by the time you give a regular 2 times your ED95 drug a dose, and by the time you're rotating the bed to position the patient, they're back. So you need to be very conscious. This can be very marked, particularly with Tegretol. Other things to be aware of are increased demethylation of iperidine in patients on phenobarbital. This is not really something that we're ever going to really have to worry about, I don't think, except it's worthwhile knowing that, as all of you know, that normeperidine is lowers your seizure threshold. And so, in general, we don't use Demerol in patients who have a history of seizures, although we are unlikely to give enough to create an actual problem. Also, increased metabolism of midazolam. If you give a PO dose, when this was studied, a PO dose of midazolam was given to patients not on Dilantin or Tegretol, and a PO dose was given to patients who were on Dilantin and Tegretol. And the plasma concentration first pass effect through the liver of an oral dose reduced the plasma concentration 90%. So it can be a very dramatic effect. I wouldn't rely on it, but it's an interesting thing if your patient doesn't get sedated after you give midazolam. It also, midazolam also decreases, the anti-epileptic drugs also increase the metabolism of Decadron and a variety of cardiac drugs. The third thing we need to know about is how to give these drugs. And there are 4 drugs that can be given IV. Phenobarb, or commonly given IV. Phenobarb, Depakote, Keppra, and Dilantin. Okay? And the main issues with Depakote I've never seen given IV intraoperatively, frankly. And so if I've never seen it, it's probably fairly uncommon. Keppra and Phenobarb, Keppra we give all the time, Phenobarb we give rather occasionally. The main issues with Keppra and Phenobarb are additive sedation. So better to give them at the beginning of the case, not during emergency if you can avoid it. But Dilantin, on the other hand, there are really significant things that we need to know about it. It's probably one of the most dangerous drugs that we give intraoperatively. And it's worth knowing that the LD50 is 2 grams IV push. So, and if you have a 100 kilogram patient, your loading dose is 1.5 grams. So we're using doses that are potentially have significant side effects, including the most common hypertension. I think everybody here has seen that. But arrhythmias like bradycardia, asystole, VTAC, VFib have also been reported. Hypertension is more common in the elderly, the frail, and people with significant cardiovascular disease. So you'll read in the guidelines that the maximum dose is 50 milligrams per minute in an adult and 1 to 3 milligrams per minute in children. But again, that's for emergency situations, and always we should give the drug substantially slower than that when we have the option of doing so. The other thing to be aware of is that Dilantin can have a very serious sequelae administration when given peripherally called purple glove syndrome. This is a fairly rare complication, but definitely occurs in a clinically significant number of patients. The reason for it is not entirely known. It occurs with Dilantin and with phenytoin and phosphonetoin, so it can occur with both drugs. It's occurred with oral administration of Dilantin, which is pretty amazing. But most of this is actually with oral drug. But generally it's thought that the drug either precipitates, the drug extravasates, either because the IV has caused a micro perforation in the vessel, or because the drug itself causes endothelial leakiness.
So this happened from oral administration?
It has been, well, there's one case report of it happening with oral administration, but most of the time it happens with peripheral administration. So the main issue I think for this is that you should always give it in the largest IV you have. You should always give it, you shouldn't, you should like look at the dilution to make sure it's not precipitating. You should always use the filter, even though people think it doesn't make any difference, because in some percent, which is less than 5, but probably more than 1.
Have you seen it?
These things will happen. No, I've never seen it, and I've given quite a few doses of Dilan. So make sure your IV is running. Give it according to the hospital policy, and be aware that if you give a lot of Dilan, at some point you may see this, and it wasn't your fault, probably. Okay. Let's go to another interesting thing about...
Does that happen immediately after you give it? Like, would you stop the infusion immediately, or it happens days after?
It can happen in both ways. If I ever saw anything looking like that, I would immediately stop it.
Is it ischemia, or just some reaction?
No, they get necrosis
Okay.
of their tissues. But usually they recover. That this patient's hand, this is not pre-op, this is post-op, post-reaction. So, okay, another interesting thing about Dilan is it augments neuromuscular blockade. And that's because, as I said, it probably decreases the amount of acetylcholine that is released at the neuromuscular junction.
Oh, so that happens fairly quickly. Like within.
Yeah.
So I thought that was like, days and days.
No. This is augmentation. So days and days are probably required to cause the rapid metabolism, the effect on the liver enzymes, and the rapid attenuation of effect. But this is acute administration in somebody not on Dilantin will augment your block. Worthwhile to know, although since God has made Sugamidex, we can worry about it less. All right. Workup for epilepsy surgery. Patients who undergo epilepsy surgery go through a major workup prior to surgery, and they undergo surgery when medical therapy, they're considered a candidate when medical therapy fails, when their seizures are enormously debilitating, or when their seizures can only be controlled with intolerable side effects of medication. Workup is looking for both lesions, obviously structural lesions on MRI, EEG, and magnetoencephalography are both studies that are done to define the seizure focus, and then they also undergo functional imaging like PET and functional MRI, and WADA testing, which is an intracarotid injection of aminobarbital to basically anesthetize one hemisphere and determine where language and memory are. So they undergo all of this testing, or many of these tests, prior to coming to surgery. And the purpose of this is, of course, to define the focus, because if they're going to do a resection or an ablation, they need to know where the seizures are coming from. And second of all, to make sure that the seizure focus can be, do you want to share?
No, we were talking about WADA testing. I never heard of that before. Never heard of that.
Really?
Yeah.
Oh, well, that's good. I'm glad you know about it now. John WADA developed it in 1955 in Canada, or 1946 sometime. So he was a neurologist. And oftentimes it's translated into the chart as a water test. Because
water.
Anyway, what was I saying? Okay, so basically the whole point of this whole thing is define the seizure focus and make sure that we can remove it, or at least we think we can remove it without a major deficit or problem for the patient. Okay, so the last 20 minutes we will talk about surgery that's done. So basically there are surgery falls into 4 categories. Procedures that are done to decrease the seizure frequency, vagal nerve stimulators, intracranial stimulators. Procedures that are done to define the seizure focus, depth electrode implant, subdural rivet placement. Procedures that are done to resect or ablate the focus, like temporal lobectomy, focal resection, taking out the whole hemisphere and laser ablation, and procedures that are done to prevent spread. So it's worthwhile sort of like thinking about these different categories when you're thinking about your anesthesia plan, what the purpose is. And when you're formulating an anesthesia plan, you basically are going to go down one of two roads, okay? One road is, during this procedure, my major concern is I don't want the patient to have a seizure during the perioperative procedure, okay? So you want to suppress seizures. So that would be one type of anesthesia plan. And it's worthwhile knowing that the incidence of seizures perioperatively in patients having non-epilepsy surgery who have epilepsy, does that make sense? Is 3 in 100. So these things happen commonly. So if your if your plan to suppress seizures fails, you shouldn't feel bad. And on the other route, the other kind of anesthesia plan would be a plan where we don't want to suppress seizures because we want to do some kind of mapping perioperatively that allows us to further define the focus. Okay? So, so if you're going to do an anti-seizure plan first, what are you going to do? You're going to make sure the patient takes their anti-epileptic drugs. If you look at studies about what kinds of things make it more likely, that is the really clear precipitator of perioperative seizures. Consider parenteral substitutions for anti-epileptic drugs if the patient's going to be off their anti-epileptic drugs for multiple doses and miss them. Use medications and agents that are anticonvulsant. Avoid medications and agents that are proconvulsant. We'll discuss that a little bit more. And consider a benzodiazepine pre-medication. And avoid non-therapeutic hyperventilation. Because there are a lot of things that happen perioperatively that precipitate seizures. Stress is one of them. Lack of sleep is another. We're not controlling those. Missing your doses of medications and hyperventilating people when they don't need to be hyperventilated. Now, just briefly, since we don't have that much time, if you're looking at what anesthetic technique to consider, your first choice is going to be benzodiazepines and hypnotics. So the benzodiazepines are anticonvulsant. Thiopental and the barbiturates, anticonvulsant. Propofol is anticonvulsant, although there are some cases of people having propofol who had seizures. So this is from a table. This is a really good paper and basically has these tables and goes through the different studies that have looked at these issues. But this is kind of the summary since we have 15 minutes. You should use caution or avoid methotrexate and etomidate because although they can be used to treat, both of them can be used to treat status, interestingly enough, they're proconvulsant in lower doses. It's very confusing. And ketamine is anticonvulsant. It can be used to treat status, but similarly, there are reports of seizure-like movements. There are reports of epileptiform activity in patients getting ketamine. So bottom line is your first choices are going to be the benzodiazepines and propofol, and and the other drugs are probably drugs that you would avoid unless there were a specific indication for it. And with regard to inhalation agents, ethrane and sevoflurane are proconvulsant under certain conditions. So I mentioned that specifically because it's under certain conditions that I think is the important part of this sentence. Greater than 1.5 MAC shouldn't be necessary in most situations. And rapidly changing concentrations, so when you're going from 0 to 5%, and hypercapnia are the things that make more likely to have a seizure with sevoflurane. We're obviously not using it, enflurane, it's not available. And so if you're going to use sevoflurane in a patient with a seizure, you're going to mitigate these in various ways. You can use nitrous with sevo, you can use a benzodiazepine pre-med, and you can not increase the concentration from 0 to 5% in 30 seconds. So I think that in most cases, you don't need to be overly concerned about that association. There's been no, as far as I know, clinically reported sequelae from the use of sevoflurane not excluding those circumstances with use intraoperatively in patients with epilepsy. Desflurane and isoflurane, on the other hand, are definitely anticonvulsant. No reports of them being proconvulsant, and sometimes they actually treat patients in the ICU who are in status, who have super refractory status with desflurane and isoflurane. Any questions about that? No? Okay. This is sort of comes into, you already know this. You have that sort of big picture in your head.
Yeah,
okay. There are a couple of drugs that you probably shouldn't give to patients with seizures, although the likelihood of them causing any problems is very low. So Demerol because of normoperidine, but you have to give quite a bit of Demerol before that would normally be a problem. But be cautious. I wouldn't give it because it's going to. If 3% of seizures, patients with epilepsy are going to have a seizure perioperatively, and you give them Demerol, it's going to be the Demerol. So just for that purpose, avoid it. Atracurium has a proconvulsant metabolite, lidanosine. It says atracurium too. You have to give massive doses for like a day before this would be a problem. It's an infusion, so I don't worry about it, but I wouldn't use it. We don't have it, so it's not a problem. Haloperidol, similarly. Tramadol, Reglan, scopolamine all have warnings about not being used in patients with epilepsy. Probably not haloperidol in the doses that we give it. Probably a very low risk. Tramadol also probably a very low risk. Similarly, Reglan and scopolamine, but I would be cautious about
What's
their
the
use.
relevance of the photo?
It's a doghouse. They're in the doghouse.
Okay.
Years ago, when I was giving a lecture to somebody who told me never put a picture that doesn't have some relevance to what you're talking about.
I'm sure that I knew there was relevance. I just didn't.
I thought that it made sense to
It's
me.
over my head.
It made sense to
No,
me.
no, it
when
makes
I put
sense.
it there.
Makes sense now.
All right. So now, one road we've been down is the anti-seizure anesthesia plan, and the other one is the anesthetic plan not to suppress the seizures. And the reason that we need those plans is sometimes we map the seizure focus intraoperatively. And we map the seizure focus intraoperatively with grids of electrodes like that are placed on the surface of the brain, which is called electrocorticography. And the electrocorticography reveals an EEG pattern that is pathognomonic of an epileptic focus that is sitting there, not doing anything, waiting to cause a seizure. And the descriptor of this pattern is spike wave activity, and I think you can see the little spikes going across. And a lot of drugs that we give in anesthesia, all of the inhalation agents, all of the hypnotics and the benzodiazepines reduce the frequency of those spikes. It's been quite well studied, and so we have to be concerned about the potential effect of those agents on this spike wave activity and our ability to construct a map that we use preoperatively to guide the resection and postoperatively to define that the resection has been helpful to the patient. The drugs that don't affect electrocorticography that we use perioperatively are opioids and dexmedetomidine. Okay, so does that mean we're doing general anesthesia, we stop everything and run dexmedetomidine alone with narcotics? No, we don't do that. But we do have a way, we do use a protocol that at least theoretically reduces the risk as much as possible that we've been using at UCLA for many, many years that we feel comfortable with. That said, some centers perform all epilepsy surgery unless there's some specific contraindication with the patient awake. Some epilepsy centers always put these grids in at craniotomy 1, send the patients back to the floor, map, and bring them back and do a resection and a second craniotomy. And some, like we, use various kinds of modified protocols. We use nitrous oxide 60% and remifentanil usually. And some people use dexmedetomidine too. And the point being that we have been able to have a great deal of success with that protocol, but there are various ways of doing things that you might encounter. So you just want to know get the lay of the land and what the local protocols are. if you are going to do these kinds of procedures. Now, some centers, not ours, also will, to circumvent that whole problem, will use triggering agents. So they'll give drugs that activate the seizure focus in patients with epilepsy during the actual mapping procedure. And the reason that this is controversial is there's sort of an enduring question: would the patient have a seizure if we didn't give them that? I mean, would you see activity in this area if we weren't giving these proconvulsant drugs? But it is interesting to note that bolus doses of fentanyl, alfentanil, remifentanil, as well as methylhexatol and etomidate can be used to produce this effect. The reason I mention it too is that we give a lot of drugs that suppress the seizure threshold when we give bolus doses of remifentanil to intubate without muscle relaxant, but certainly this dose is in the range of the doses that we use in that scenario. So now we've got our plan. We got the patient at the front desk. So I always ask patients, literally, I always ask them these questions. What happens when you have a seizure? How often do you have them? When was the last one? Is there a warning symptom? What anti-epileptic medications are you taking, and have you been taking them on schedule? Because I want to know this before I start any case. And it's more than just reviewing the chart, because you find out a lot of interesting things when you talk to people about their seizures. Just last week, we had a patient come down, and the patient told me that, usually I have to have the family members, of course, tell you, but the patient's mom told me that she starts having this kind of like choking sound right before a seizure. Or if you're doing an awake craniotomy in a patient with seizures, it's useful to know that afterward they're asleep for 2 hours, or afterwards they breathe in a strange way, or afterwards they throw up and start attacking people. I mean, these kinds of things, you do hear these stories, and it's worthwhile knowing. And also, it's worthwhile knowing if the patient has some symptom before. Because if you're doing an awake craniotomy and the patient says to you, I smell roses, and that's their aura, you know the patient's about to have a seizure. That can be very useful information. So find out about the morphology of the seizures. How often you have them, more often people have seizures, the more often they have seizures perioperatively, worthwhile knowing. Also, the time to the last seizure is actually also predictive of a perioperative seizure. And people are changing their anti-epileptic medications. The surgeons are stopping them or starting them or changing them. So it's worthwhile to review that when in each case before you take the patient to the OR. All right, now in the next 5 minutes, I've got to go through special considerations for all of these procedures. And so we'll go through it fairly rapidly. So the procedures to decrease seizure frequency that we do are 2, vagal nerve stimulators and intracranial stimulators. Vagal nerve stimulators can be done under general anesthesia. You could use an endotracheal tube or an LMA. We normally use an endotracheal tube. Some surgeons like to have the patient be unparalyzed after a while during the procedure, so that if they have put the electrodes around the vagus nerve and gotten the phrenic nerve, they can see the diaphragm move. Although the diaphragm is very resistant to neuromuscular blockade, it's probably actually not necessary. And we need to anticipate several things. One, bradycardia. There's a 1 in 1,000 chance of severe bradycardia, asystole. Even people had to do CPR when they're testing the device. Many of these patients experience postoperative hoarseness due to the proximity to the recurrent laryngeal nerve, and some of them experience hoarseness throughout the time they have the stimulator every time it is activated. And it can exacerbate sleep apnea, so if you have a patient with sleep apnea, worthwhile discussing that with the surgeons in case they don't know. Usually they will then gradually activate the device under controlled circumstances. We also do procedures to define the seizure focus. 2 kinds that we do are depth electrode implants and subdural grid placements. The main issue for depth electrode implants is that it's a stereotactic procedure, and the patient has this giant frame on, and if the giant frame is on, it's very hard to manage their airways. So some people do depth electrodes actually with sedation and without airway management. some places do them with general anesthesia. We do them usually with general anesthesia, and usually they put the frame on before, which means that we have to figure out a way to manage their airway either with an LMA or a wake fiber optic. Those are the two options. So basically the frame is the main issue for that case. And anytime you're putting any kind of a probe in your brain, you might want to think about what am I going to do if the patient suddenly needs to have a craniotomy, which does happen, not frequently, but occasionally. Subdural grid placement involves a craniotomy, general anesthesia. They may do electrocorticography, in which case you need to have that plan of changing your anesthetic technique in the middle of the case so that you can accommodate the electrocorticography. Okay, so in terms of procedures to resect seizure foci, there are a variety of different kinds of focal resections that you can do depending on where the seizure is. One of the most common is temporal lobectomy. If you're doing temporal lobectomy of the non-dominant hemisphere, that's usually general anesthesia. Obviously it involves a craniotomy. They may or may not do electrocorticography. Often they do, so you need to have a plan for that. Better not to give benzodiazepine pre-medication, because if the spike wave activity is not there, it will be blamed on the benzodiazepines, although obviously it's probably unlikely that that would actually be the cause, but better to give the patient the best chance of having the best mapping possible. And you might need to administer triggering agents. We don't do that here at UCLA, but UCSF they do, so there's a lot of different variety of management protocols. And when they do retraction on the temporal lobe, it's not uncommon to see bradycardia. So as they're doing their resection, you have to communicate with the surgeons. Usually if they just stop retracting, it goes away. But rather dramatic pauses, such as this one, which was reported in the case report a few years ago, can happen. So that's non-dominant hemisphere. If the dominant hemisphere has been determined by the Wiele test, then and you're doing it in a procedure in the dominant hemisphere, then when you do a temporal lobectomy, once you get far, if the lesion, if they're doing, it's not the very anterior part of the temporal lobe, then you may involve speech. So those patients have to be done awake. Usually they have a functional evaluation before functional MRI. And you need a technique that can accommodate electrocorticography, motor mapping, and speech mapping, which means an awake craniotomy usually, which can be done with local anesthesia plus sedation, or like we do here, asleep with general anesthesia. Awake up in the middle of the case, and then general anesthesia again. Another procedure that is to resect seizure foci is hemispherectomy. I don't know, has anybody ever done one of these cases? Okay. So it used to be, these cases were very exciting because we almost always took out the entire hemisphere. Now they do more restricted resection, and then they actually disconnect the two hemispheres. So that's the difference between anatomic and functional hemispherectomy. So now they do more functional hemispherectomies than anatomic hemispherectomies. But either way, the blood loss can be very significant. This is a review, I think, from a little bit more than 10 years ago, and everybody was losing 50 cc's per kilo. And this is a procedure that's mainly done in children because removing the hemisphere is generally better if the patient has a fair amount of neurologic plasticity. Although you'd be amazed, we used to do these functional anatomic hemispherectomies. We remove the hemisphere and the patients would wake up and they'd be moving both sides. And the reason for that is that as the hemisphere becomes more and more damaged, those functions are lateralized to the other hemisphere because of plasticity. Anyway, so the main issue is significant potential blood loss. We've got 2 more minutes here. Okay, so the 2 more procedures that you need to know about is one, laser ablation, which is a procedure we just started doing at UCLA, and I think that it's going to be more and more frequently done. This involves making a burr hole, taking a small laser probe, and actually stereotactically, after placement of the frame, putting the probe into where the seizure focus is. Then we take the patient back. Usually we go CT scan, come back, put the probe in, then we go to MRI, where they do MRI guided thermotherapy. So basically what happens is that they heat up the end of the laser probe dramatically, and that ablates the seizure focus. These patients are remarkably, minimally affected by this procedure. They have very little postoperative pain, and many of them are going home the next day.
Wow.
So it remains to be seen, of course, the results, but this, I think, could be a significant part of your future. The main issues during these cases are once they put the laser probe in, it's a good idea for the patients not to move, although some centers are doing them under just with sedation. We use general anesthesia. And then all the issues of doing general anesthesia and MRI also come to play. And the last procedure that we do very, very rarely, but still we use is corpus callosotomy, which is done in the head-up position near the sagittal sinus. Bleeding and venous emboli are risks, and they may do ECOG to confirm disconnection of the two hemispheres. They actually look to see whether the two hemispheres have the same spiking. I want to say a couple of other quick things before we go. So these are some things that I learned over the years that are useful to know. Seizures tend to occur around induction and emergence. So if you think you've gotten through the whole case, watch out during emergence. Number one. Number two, prolonged seizure activity is harmful. In patients with poorly controlled seizures, consider monitoring during GA or keeping the patient unparalyzed or having some way of knowing that the patient is having a seizure. Seizures increase CBF and ICP dramatically. So if you have an open craniotomy during general anesthesia or in an awake patient, this could be a big drama. You've got to have a plan for controlling it. When we stimulate the brain to arrest speech, patients can have seizures. It's a potent stimulus for a seizure. Don't start the case without cold saline, which they put on the brain, which stops the seizure, and a plan if that doesn't work. And finally, seizures are a herald of a whole slew of bad things. Know what the patient's seizure is like, okay? Because seizures can occur for all kinds of other reasons. Intracranial disasters, metabolic abnormalities, drug effects, etc. So always keep the whole diagnostic options open in your mind. And usually it's the patient's having their normal seizure, but consider that it might not be. All right, so thank you very much for your attention. Sorry to go into your time, John. I will stop talking.